So now this is where I think we really come up against the critical issue that underlies the tongue-tie epidemic, and that is that clinical breastfeeding support has not been a research priority. So we have had 50 or 60 years now of investment in research about the nature of human milk and why human milk is best for human babies. This has been very important, but unfortunately there's not yet been the research investment that's required in clinical breastfeeding support, how we get that wonderful human milk directly into the bubby's gut in a way that's pain-free and efficient, in a way that's workable for that mother and baby. So this is actually a frontier.
Right.
This is pioneering, and I would argue it's because of this frontier and the difficulty we have actually offering mothers and babies tools that really help with their breastfeeding problems, that we think, only because we care so much, we think, well, maybe it is the oral connective tissues. And of course there is that whole history of tending to look for simplistic structural problems, linear causal.
Absolutely. Snip or laser or fix.
That's it.
Ta-da!
That's it. And of course we know from the research that it's typically not all fixed, that it's not helping our breastfeeding mother-baby pairs. And of course from 2005, all the research that's been conducted really has been very confused around definitions of tongue-tie, has significant methodological weaknesses. It's possible that it's both overestimating the benefits of frenotomy for the posterior tongue ties and upper lip ties at the same time as we're underestimating benefits for classic tongue ties. Overall, our Cochrane review, for instance, that came out almost 2 years ago now, and a couple of other big systematic reviews are showing no really convincing evidence of benefits for frenotomies.
So Pam, you've mentioned there, and I just want to go back because I think this is important, the lip tie, that we can demonstrate that that upper lip moves beautifully, universally, even if there is a strong frenulum that goes right down to the gum and maybe even tucks a little under. But lip tie is one of the things that women present to me having already had babies having it divided. So is lip tie not a thing?
It's actually not a meaningful diagnosis in any way. So the Australian Collaboration of Infant Oral Research published a position statement on these diagnoses of upper lip tie and indeed buccal tie in 2017. And we showed through a careful analysis of existing evidence and also expert opinion across multiple university sites that the diagnosis of an upper lip tie is meaningless because we're really looking at a whole range of normal anatomic diversity. But worse than that, brings potential risks if there's a frenotomy performed.
What sort of risks?
There's a risk of bleeding actually, and a risk of infection.
Right. Is that just with the scissors or is that with laser as well?
Laser, of course, better controls the bleeding, and it's why the dentists preference it. They can actually perform more invasive surgery, but ensure hemostasis. Now, labial frenulum frenotomy increases that baby's risk of scarring and diastema between the incisors down the track. Now,
What is a diastema for those who don't know?
A separation between the two front teeth.
Oh, like that thing Madonna has? So the gap between the teeth, I thought that was something that the frenotomy was supposed to fix.
And this is what parents are being told, but it's misinformation, because these babies are being subjected to increased risk of scarring, which leads to an increased risk of diastema, or that separation between the teeth.
So we should leave the lip alone?
There's absolutely no role for a frenotomy
and the
of a labial frenulum.
Stuff, that's
absolutely no
forget
role
that.
for surgery.
The classic tie where maybe we're 100% it's not the figure, but it is tethering that tongue.
So a clinical judgment.
The posterior tie.
Yes.
Posterior where?
This is a very good question. The new work by Dr. Nikki Mills, an ear, nose and throat specialist from the Starship Children's Hospital in Auckland, and an anatomist, shows that there's a complete misconception around the anatomy of the lingual frenulum.
Mm-hmm.
It's often described as a cord or a mast, as a discrete length of tissue. But in fact, it belongs to floor of mouth fascia that's suspended from the arcs of the mandible and connects to the base of the tongue, the undersurface of the tongue. And when the tongue is elevated, then there's naturally tension placed on this spread, like this fan-like spread of floor of mouth oral fascia. And it's the tension of the tongue elevating that actually exposes what looks like a cord or a band, but is actually just the tenting of this structure, which is a contiguous piece of fascia. So there's a great deal of misconception actually around the idea of a lingual frenulum, and the idea that somehow in severing that we're actually releasing a discrete piece of connective tissue. So when we're looking at an anterior membrane, it's typically low in vasculature, and we assume low in nerves, doesn't have much in the way of what I'm referring to as an anterior membrane is a translucent piece of variably elastic tissue that really does seem to run along the undersurface of the tongue. That's 20%, 50%, perhaps to the tip. So that's an anterior membrane, and sometimes we might cross over into thinking clinically it's restricting the mobility of the tongue. It truly is a classic tongue tie, let's snip it. But many of us will feel prominence, if you like, under the tongue.
So help me with mine now.
Yeah,
Okay.
I'll do my best.
Here you go. All right, so,
Lingual frenulum,
Okay.
what we call a lingual frenulum.
All right.
But it's really a
and so they're going in, because when I think classic tongue tie, I think, like it's more than what I've got out.
Yeah, yeah.
And so you're going in and under the tongue,
Yes,
and
that's
snipping
right.
that off so that it goes back to closer to what I've got, because I'm normal.
That's it.
Or just
That's
enough
it.
to release that tongue.
That's it.
Yes, okay. But with the posterior tongue tie,
So they'd want to cut that deeply, diamond-shaped wound, and
so it's a diamond-shaped wound because you're cutting into a tenting thing, so it opens up, or they cut a diamond shape.
no,
They cut
it's because
across.
you're cutting into some
Yes, the tenting, yes.
and it opens.
So that leaves a raw area under the base of the tongue.
Yes, quite a large area. Now, of course, the fact is that this scars up, and this is one of the side effects. There's a number of risks associated with, in particular, this deep laser frenotomy.
And I think this is one of the things that, because it messes with my head, like what on earth are they talking about? Because I look underneath and I go, that's normal. Because it is.
It is.
Yes, but we're calling normal abnormal.
Yes.
But we weren't calling abnormal, and so it's that mix, and that's part of the problem that we have.
Yes, yes. I think in summary, when we're talking posterior tongue tie, we're talking a diagnosis that labels normal anatomic variance as abnormal, inviting intervention that doesn't help breastfeeding outcomes, doesn't improve outcomes in terms of speech or orthodontic development.
We
Indeed.
have research on that. I mean, that's not just you picking that out of your head.
What we know from the research is that breastfeeding itself improves orthodontic outcomes. So that's been nicely established actually in a systematic review of studies. However, advocates of frenotomy for blurred diagnoses around tongue tie or posterior tongue tie are claiming that therefore an intervention of a frenotomy will improve orthodontic development. So we've seen this link between breastfeeding and improved orthodontic development, and then the assumption that a frenotomy for these diagnoses will inevitably improve breastfeeding and therefore improve orthodontic development. But of course, this is an assumption which in fact doesn't make sense from a physiological point of view, actually.
So the classic tongue tie, where you have that sort of extra bit of membrane that extends underneath the tongue and close to the tip, that tethers that tongue so that it has difficulty reaching out and does the little heart shape. That is different to a point where you lift the tongue up, what you were saying about the tenting, and that giving the impression that at that point there's a pullback on the tongue. So that is cut or lasered into that tented tissue, creating then, once that's cut, then you get the diamond shaped wound. Will that reattach? Is that a raw area that's just going to reattach? Because I hear parents say that they've got to do exercises to stop it reattaching. And I have a whole lot of concern about babies who don't want things put in their mouths. They have an oral aversion. They don't like things going in their mouths. Does it hurt? Is it raw? What's your experience?
I think it does hurt, and parents do say they don't like to do it because it upsets the baby and therefore upsets them.
This is the exercises or the procedure?
This is the wound. Well, I think both. If we're talking laser frenotomy, I think it's clear that it hurts babies. And if we're talking wound stretching exercises, parents report that it causes the baby to become upset, and this can be prescribed 4 times a day or so for 3 weeks. Also, of course, there's a failure to understand the nature of wound healing happening here, because it is true that these surfaces are going to want to heal and scar and move towards opposing again. The idea that we can interfere with that by 4 times a day wound stretching. If you talk to someone like Laurie Walsh, who's an expert in terms of oral wound healing, he would argue there's serious misconceptions here. But we do see, of course, that the tissues contract down. This is the nature of scarring or healing.
Yes.
And I not uncommonly see quite significant and contracted healing under the tongue. So the idea that we're somehow allowing tongues increased extension and mobility through these deep laser treatments, again, is really of concern.
It actually sounds like it might make it worse.
I think actually that's a risk for some.
You're swapping a physiological elastic tissue for a contracted, scarred, not so elastic tissue.
Yeah, that's right. But
and upsetting baby.
There's also
and upsetting mum.
the risk of cutting the lingual nerve.
Okay.
And this is something that Nikki Mills raises in her work around the anatomy of flora of mouth. It does seem that there's a real risk that these nerves are being severed in our babies, and the babies are not going to be able to communicate to us if they have some numbness of the tongue. As you mentioned, there's concerns around oral aversion, and often these are babies who are already dealing with a conditioned dialing up at the breast, so I'll often see little ones with worsened conditioned dialing up or oral aversion after their laser frenotomies.
So babies that were already a little bit fussy when they went on the breast, now anything's going near their mouth, they're even more worried and upset and fussy and irritable. That doesn't sound like a recipe for good breastfeeding.
I think it's terribly concerning.
Yeah.
I am keen to communicate to people about is the findings when we really look at the ultrasound studies that have been done here in Australia with the Human Lactation Research Group, but also internationally. When we look closely at what these studies are showing us, the biomechanical model out of which these diagnoses of posterior tongue tie, upper lip tie have arisen as solution for breastfeeding problems is inaccurate. When we look at the ultrasound studies, we see a model that we've called in this 2017 paper the Gestalt model of infant suck and swallow and breastfeeding. And it's out of that we've developed the Gestalt breastfeeding approach.